Welcome to the anatomy class by the MEDI EXPRESS team. Today we are going to deal with thorax, abdomen, and the lower limb. So the first topic in the thorax which we are going to see is a little about intercostal muscle. You can see the muscles over here. About the intercostal muscles we will deal in detail, but here what I want you to know is uh, just the names. The innervation now we'll deal later. Okay, so the muscles of the intercostal space are external intercostal muscle. You can see over here, external intercostal muscle. We have internal intercostal muscle, as well as in between we have innermost intercostal muscle. Okay, now in between the internal and the innermost muscle, we find the neurovascular bundles. In between the internal and the innermost muscle, we find the neurovascular bundle. This is what you have to remember. Okay, now there is a little difference in the arrangement of the intercostal, veins, arteries, and nerve. Now you have to remember that in all the intercostal spaces, okay, in all the intercostal space, the arrangement of vein, artery, and nerve is intercostal vein first, then it comes intercostal artery, and then intercostal nerve. You can remember vein, artery, and nerve. That is above downwards. But except in the first one, in the first intercostal space, the arrangement is nerve, artery, and vein. Just the opposite of it. This is something which you need to remember, and it is very important. So remember, the arrangement of the vein, artery, as well as the nerve is very important. In all the other, we have vein, artery, and nerve. But in the first intercostal space, it is nerve, artery, and vein. Okay, they can remember as vein. This is the one which is very important, and I want you to remember this. Okay, so the next one we are going to deal with is intercostal veins. Now, talking about the intercostal veins, we have already dealt it when we were talking about the venous drainage of the entire system. But here, only a gist about it, or else if you remember whatever was taught, it is just a revision. Okay, so the intercostal veins, remember, over here we have an accessory hemiesophagus vein. Accessory hemiesophagus vein, we have a hemiesophagus vein, then we have the right superior intercostal vein. Okay, right superior intercostal veins over here. All these, they drain into the esophagus vein. Esophagus vein you can see over here. So may it be the accessory hemiesophagus vein or hemiesophagus vein and the right superior intercostal veins. These drain into the esophagus vein. But here you can see your vein. I'll mark it in red. It comes outwards, and that is called as a left superior intercostal vein. So among the intercostal veins, hemiesophagus vein, accessory hemiesophagus vein, and intercostal veins, that is superior intercostal vein, they drain into the esophagus vein, but except for the left superior intercostal veins. This is yet another pointer which you need to remember regarding the intercostal veins. Okay, rest all the other branches and all that we have already dealt it. So next one, a little important one. We talk about the embryology of the heart. Embryology of heart is a little important topic. Now, talking about the development of the cardiovascular system, remember that the cardiovascular system is one of the first body systems to appear within the embryo. It is the first one, or the one of the first body system to appear within the embryo. Okay, now this is active by the beginning of the 4th week. By the beginning of the 4th week, this particular development becomes active. Okay, now so you can see over here, these are the primitive heart tubes. Primitive heart tubes. Okay, primitive heart tube. Now we'll see in detail what are the things a primitive heart tube will be having. So here we're talking about primitive heart tube. Okay, now there are 6 regions. Remember, there are 6 regions for primitive heart tube. The first one is aortic roots. Otherwise, we can tell it to be arterial poles. Second one is a truncus arteriosus. Third one we have bulbus cordis. Next we have ventricle, atrium, and lastly sinus venosus, otherwise termed as a venous pole. So these are the 6 regions of primitive heart tube. Now, once again, that is aortic roots, truncus arteriosus, bulbus cordis, ventricle, atrium, and sinus venosus. Now let's see the picture over here. So you can see we have a truncus arteriosus, first one, then bulbus cordis, a ventricle, atrium, and sinus venosus. And over here you can see these are basically the aortic roots, okay, which forms the aortic arch and all that. So aortic roots we have. Now, what you need to remember regarding the embryology of the heart is the development of the heart begins on the 16th day. The development of the heart begins on the 16th day. This is very important. And the heart beats we can hear by, or it starts developing by 4th week. Heart beats by 4th week. So development of the heart begins by 16th day, and the development of the heartbeats start by 4th week. Now, coming to a little detail about the sinus venosus. Okay, right over here. At 4th week, what happens you need to remember. Okay, now this particular sinus venosus which is there, the sinus venosus is responsible for the inflow of the blood to the primitive heart. Okay, and inflow of the primitive heart, and it empties into the primitive atrium. Okay, now what you need to remember with regards to this is, from where does this blood come? It receives the venous blood. Remember, it receives the venous blood from right and left sinus horns. This is something which you need to remember. Okay, at around 4th week, the sinus venosus, it becomes responsible for the inflow of the blood to the primitive heart and empties into the primitive atrium, and they receive blood from the right and the left sinus horns. Now coming to the information, the blood enters through the sinus venosus, we have already said, and the truncus arteriosus, the blood moves out of it. Now we already know with which the blood comes in, and that is sinus venosus. But now we also need to know from where the blood goes out, and that is truncus arteriosus. Okay, blood moves out of it. Now, coming to another information regarding the right and the left horn. Okay, so over time, what happens as the sinus venosus is already supplying the blood? So what will happen is, after some time, the venous return shifts to the right side of the heart, and because of that, the left sinus horn will recede, and then the left sinus horn will form a coronary sinus. So once again, I'll repeat: the venous return will shift to the right side of the heart. Venous return will shift to the right side of the heart. Okay, and thus we have a left horn left. So left one, what will happen is it will recede and it will form a coronary sinus. And this coronary sinus is responsible for the drainage of, right? Drainage of venous blood from the heart. Okay, so we had two sinus horn, then that is first one is right sinus horn and the left sinus horn. Okay, this left one will become coronary sinus. Okay, now what will happen to the right sinus horn? Right sinus horn. Now we've already said venous return will shift to the right side of the heart, right? Now the right sinus horn will be enlarged and it is absorbed by the growing right atrium. Okay, so the enlarged right sinus horn is absorbed by the growing right atrium and eventually it forms a part of inferior vena cava in the adult. So this one becomes a part of inferior vena cava. Okay, so this is the fate of left sinus horn and the right sinus horn. So once again, I'll repeat. Please listen carefully. At around fourth week, the venous sinus is responsible for the inflow of the blood into the primitive heart, and it empties it into the primitive atrium. Now, from where do they get the blood? They get the venous blood from the right and the left sinus horn. So here, right and the left sinus horn. Now, what will happen after some time is there will be a venous return that is shifting from right side, shifting to the right side of the heart. And because of that, the left horn will recede and will become a coronary sinus. Okay. And this will be responsible for the drainage of venous blood from the heart itself. Okay. The next one is about the fate of right sinus horn. The enlarged right sinus horn is absorbed. Remember, it is absorbed by the growing right atrium and eventually forms a part of the inferior vena cava in the adult. So, this is what happens to the right sinus horn and the left sinus horn. In the left atrium, similar way, similar process happens with the pulmonary veins. Okay. So next one is a truncus arteriosus. A truncus arteriosus will be developed later on in an adult as ascending aorta and the pulmonary trunk. Ascending aorta and pulmonary trunk. Important one to remember. This was asked. Then we have a bulbous cordus over here and the ventricle and atrium. They will become a proper atrium and the ventricle. Okay. So truncus venosus, this particular part, it will become ascending aorta and the pulmonary trunk. Bulbous cordus, ventricle and atrium, they will become the atrium and the ventricles. Okay. We have sinus venosus, right sinus horn will become a part of inferior vena cava and the left one will become a coronary sinus. This much you have to remember regarding a little regarding the embryology of the heart. Apart from that, one more thing, the cardinal veins that were there, that is anterior, common, and the posterior one. Okay, in the embryonic stage, will develop into a superior vena cava and the inferior vena cava. And we already know we have vital veins, right? They will develop into portal veins. And what forms the ligamentum teres after birth? After birth, the left umbilical vein gets obliterated as ligamentum teres after birth. But whereas the right umbilical vein, it regresses before birth. So this is the information regarding the embryology and little changes that happens after the birth. So coming to the next one is the muscles of thoracic wall. Muscles of the thoracic wall. We have when we started with the thorax, when I was telling about the intercostal muscles, we have already said that the muscles of the intercostal spaces, right? So the first three, which we already know, that is the muscles of the intercostal space, that is external intercostal, internal intercostal, as well as the innermost intercostals. So coming to the first one, that is external intercostal muscles. Whatever extra information which we have, I'll write it over here. So external intercostal muscle, you need to remember this one. What as a whole, what we say intercostal muscles means the muscles which lie in between the ribs. Okay, so they are divided into three. That is external intercostal, internal intercostal, and innermost intercostals. So first we'll deal with these three and then we'll go to the other one. Okay, so the external intercostal muscle. Extra information which you need to remember is there are 11 pairs of external intercostal muscle. Okay, now they originate from the lower border of the ribs. All the intercostal muscles, they originate from the lower border of the ribs, whereas it gets inserted, all the intercostals again, they get inserted into the upper border of the rib, upper border of the rib, just below that, okay? Upper border of the rib below, from where it starts and the next upper border of the rib, it gets inserted. And the nerve innervation is the same, intercostal veins, intercostal vein. And what does or what is the action of external intercostal muscle? That is to elevate the ribs in inspiration. Remember, elevating the rib in inspiration is the action of external intercostal muscle. Okay. And when we talk about the nerve innervation, intercostal muscle, intercostal nerves, that is T1 to T11. Okay. Now, as it elevates the rib in the during inspiration, remember the thoracic volume also will increase during that time. Okay. So next one is about the internal intercostal muscles. Okay. So again, about the origin and insertion, we have already dealt. Again, same innervation is intercostal nerve, and that is T1 to T11. And what is the action? It depresses the ribs. It depresses the ribs and elevates the ribs in the interchondral part. So costal part, it depresses the rib and elevates the rib in the interchondral part. So in a other way, I will tell you, what happens here is when it depresses, the thoracic volume of the thorax will decrease. Thoracic volume will decrease. Okay, so this is something which happens. Next one is the innermost intercostal space. In innermost intercostal space. Okay. Again, they have the same origin, that is lower border of the rib and gets inserted into the upper border of the rib. Nerve insertion is again one and the same, that is intercostal nerve, that is T1 to T11. And the action is to elevate the rib. Remember, again, its action is to elevate the rib. So these are the actions of the first three intercostal muscles. Next one, we come to the transversus thoracics. Transversus thoracis. Okay. So the origin is posterior surface of lower sternum and xiphoid, and insertion is into the inner surface of the costal cartilages, and that too from 2 to 6. The nerve innervation is again intercostal nerves here, but the root value is T2 to T6. T2 to T6. And what does it do? It weakly depresses the rib. It weakly depresses the rib. That is one important action of transversus thoracis. Next one is the subcostals. Subcostals are the muscles that are found in the inferior portion of the thoracic wall. Okay, it is found in the inferior portion of the thoracic wall. You have to remember. Then, origin is from the inner surface of the lower rib near their angle, and its insertion is upper border of the ribs 2 or 3 below. Okay. Now, coming to the innervation, it is just intercostal nerves. And the action is, again, it helps in elevating the rib. Because what happens is subcostalis usually share the action of internal intercostal muscles. Okay, that two of interchondral part, right? Yeah. These two are the same. Next one is the levator posterum. And the origin is from the transverse process of T7 to T11. And insertion is subadjacent ribs between the tubercle and angle. Here we have a different nerve innervation, and that is dorsal primary rami of C8 to T11. And it has the same action to elevate that of the rib, elevation of the rib. That is the action of levator coastrum. So the next one which you're going to deal is the superficial muscles of the back. So talking about the superficial muscles of the back, now here you have to remember the muscles are trapezius, levator scapulae, rhomboid minor, rhomboid major, latissimus dorsi, serratus posterior, superior, and serratus posterior inferior. Okay, now you can see over here the serratus posterior inferior which is being given. Now trapezius muscle. Okay, so the origin of trapezius muscle is what we are going to see now. So the origin is, it gets originated from the external occipital protuberance. You can see over here, external occipital protuberance, superior nuchal line, ligamentum nuchae, and the spines of C7 to T12. T7 to T12. Okay, so this is the origination of trapezius muscle, and where does it get inserted? You can see over here. It gets inserted into the spine of scapula, acromion, and the lateral third of the clavicle. So here, the only difference is the nerve innervation, and that is spinal axillary nerve having a root value of C3 to C4. And what it does, it helps in the adduction, rotation, and elevation and depressing the scapula. Adducts, rotates, elevates, and depresses the scapula. That is the action of trapezius. Now coming to levator scapulae, rhomboid minor and rhomboid major, they are having the same innervation. Remember, having the same innervation. Okay. Whereas rhomboid minor and rhomboid major, they have the same action also. That is adduction of the scapula. Okay. So coming to levator scapulae now, it gets originated from transverse processes of C1 to C4. Transverse processes of C1 to C4 and gets inserted into the medial border of scapula. Medial border of scapula. And the nerve innervation, you can see dorsal scapular nerve. Okay, C5 is a major nerve root value. Along with that, C3 and C4 is also included. So elevates the scapula and rotates the gynoid cavity. That is the action of levator scapulae. So talking about rhomboid minor and rhomboid major, the origin is from the spines. Rhomboid minor is originated from C7 to T1, whereas rhomboid major is originated from T2 to T5. Okay, now rhomboid minor, where it is inserted into the root of spine of the scapula, root of the spine of the scapula. Rhomboid major is, you can see here, rhomboid major, it is inserted to the medial border of the scapula. Okay, here we have the spine, the root of the spine, we have the rhomboid minor, whereas in the medial border, we have rhomboid major. Coming to the action, I've already said, adduction of the scapula. That is what its action is. Next one is latissimus dorsi. Latissimus dorsi, you can see over here. The origin is from the spines of T7 to T12. Then thoracodorsal fascia, iliac crest, and the ribs of 9 to 12. Whereas where it gets inserted to the floor of the bicipital groove of the humerus. Floor of the bicipital groove of the humerus. That is where it gets inserted to. Next one, nerve innervation is thoracodorsal nerve. Thoracodorsal nerve. And the action of latissimus dorsi is to adduct, extend, and rotate the arm medially. And also it helps in depressing the scapula. It depresses the scapula. Okay. And next one, we have serratus posterior superior and serratus posterior inferior. Okay. Again, we have same nerve innervation, that is, same nerve innervation, that is intercostal nerves. Intercostal nerves. Even the root value is different. For serratus posterior superior, we have the root value T1 to T4, whereas serratus posterior inferior, we have root value T9 to T12. Serratus posterior superior, they elevate the rib, whereas serratus posterior inferior, they depress the rib. So this is the difference between serratus posterior superior and serratus posterior inferior. Now coming to the occipital muscles of the back. Occipital muscles of the back. Now you can see the picture over here. Okay, we have rectus capitis posterior major. Rectus capitis posterior major. You can see the one in the yellow. Rectus capitis posterior minor. You can see one in the little violet color. Then obliquus capitis superior, green. Obliquus capitis inferior in the brown. Okay, so these are the four occipital muscles of the back. Now coming to the origin of it. Okay, origin of rectus capitis posterior major. It gets originated from the spine of the axis. It gets originated from the spine of the axis, and it gets inserted to the lateral portion of the inferior nuchal line. Lateral portion of the inferior nuchal line. And one thing which is very common with all these muscles of the suboccipital muscle are, of the muscles of the neck are, not neck, sorry, back are, the nerve innervation is the one and the same, and that is the suboccipital nerve. Suboccipital nerve. So when we say that, even the action of these muscles are also nearly similar. Whereas rectus capitis posterior major extends, rotates, and flexes the head laterally. Same way, rectus capitis posterior minor extends and flexes the head laterally. So is with that of the obliquus capitis. That is, extends, rotates, and flexes the head laterally. So in a literal meaning, the rectus capitis posterior major and obliquus capitis superior will be having the same action, whereas rectus capitis posterior minor and the obliquus capitis inferior will be having the same action. Okay, so if you remember only two actions, then that will be fine. So major and superior will be having the same action, minor and inferior will be having the same action. And the nerve innervation is by suboccipital nerves. This is very important to know. Now next one is about the abdomen. I hope the thorax was clear. Now coming to the abdomen. We'll deal with only the important ones in the abdomen. So the first topic is inguinal canal. Okay, you can see your picture. This is a picture of inguinal canal. Now, before I go into the other details of the inguinal canal, there are a few things which you need to know. Okay, now a little details about inguinal canal. Now remember that this is a short passage. Okay, this is a short passage that extends inferiorly and medially through the inferior part of abdominal wall. This is important to know. And it is superior and parallel to the inguinal ligament. Okay, so this is something which is important for you to know. Yeah, so there is something called a superficial inguinal ligament, superficial inguinal ring, that is present in the external oblique aponeurosis. A superficial inguinal ring which is present in the external oblique aponeurosis, and the deep inguinal ring is situated in the transversalis fascia. This is something which you need to know. I'm just telling you the key points of inguinal canal from the exam point of view. We have a superficial inguinal ring which is present in the external oblique aponeurosis, and the deep inguinal ring which is present in the transversalis fascia. Okay. Now, inguinal canal is formed by joining of the superior inguinal ring as well as the superior inguinal canal as well as the deep inguinal canal. These two. And this is very important. The length of the inguinal canal, that is 3.8 centimeter. 3.8 centimeter. Okay. Now, basically, talking about the superficial and the deep inguinal ring, they are nothing but they are the two openings of the inguinal canal. They are two openings of the inguinal canal. Okay. Now, The boundaries are anteriorly, the boundaries are external oblique muscle and the internal oblique muscle. External oblique and the internal oblique. Okay. Then coming to the posterior boundary, we have transversalis fascia as well as conjoint tendon. Superiorly, internal oblique aponeurosis and transverse abdominal aponeurosis. And inferiorly, we have inguinal ligament. Okay. But what is actually asked in inguinal ligament, inguinal canal is its contents. Okay. Now talking about the contents, let us mention in detail. Okay. The first content is the spermatic cord. I've already mentioned here. Okay. It will write again spermatic cord, then round ligament. Spermatic cord in males, round ligament in females. Apart from that, we have a ilio-inguinal nerve. Then we have genital branch, all right? Genital branch of genitofemoral nerve. So these four are basically the contents of inguinal canal. You can see the picture over here. We have ilioinguinal nerve, genital branch of genitofemoral nerve, spermatic cord in males, and round ligament of the uterus in women. So this is the one which has been asked frequently in the exams. Contents of inguinal canal. Next one, coming to Hasselbalch's triangle. You might have heard this Hasselbalch's triangle. What is the other name for Hasselbalch's triangle? That is inguinal triangle. That is the other name for the Hasselbalch's triangle. And it is a region in the anterior abdominal wall. Remember, this is a region in the anterior abdomen wall. Okay, this is, I've already mentioned one other name, that is inguinal triangle. There is one more name, and that is known as a medial inguinal fossa. So we have three names. Either it is called as Hasselbalch's triangle, or a medial inguinal fossa, or an inguinal triangle. Okay, now coming to the borders of Hasselbalch's triangle or a inguinal triangle. So medially, we have lateral border of the rectus abdominis. Lateral border. Medially, we have lateral border of the rectus abdominis, the one in the green. Okay. Now, laterally, we have inferior epigastric vessels. Inferior epigastric vessels. And in the inferior part, we have the inguinal ligament, the one in the yellow. So this is the triangle. This is the triangle which we're talking about as inguinal triangle. In one side, what we have is rectus abdominis muscle, the lateral border of it. The other side, we have inferior epigastric vessel, and in the inferior part, what we have is the inguinal ligament. So this is the borders of inguinal triangle. Now coming to the content, remember that other than the layers of abdominal wall, the inguinal triangle actually doesn't contain any other structures of clinical importance. You can see where this is just the muscles. Only some tributaries are here. Apart from that, there is nothing else. Okay, so other than the layers of abdominal wall, the inguinal triangle does not contain any structures of clinical importance. This is what you need to know about Hasselbalch's triangle, otherwise termed to be inguinal triangle. Again, one more name, medial inguinal fossa. Now next, coming to the diaphragm. Now a little detail about the diaphragm. That is, the nerve supply of the diaphragm is phrenic nerve. Nerve supply is phrenic nerve. That is, with a root value of C3, C4, and C5. C3, C4, and C5. Now the major opening. This is the one which has been asked repeatedly. There is a vena cava opening at the T8 level. Vena cava opening. Okay, T8 level. This is T8 level. Then we have an esophageal opening. Okay, and that is at the level of T10. And finally, we have an aortic opening at T12. So these are the openings. Vena cava opening at T8, esophageal opening at T10, and aortic opening at T12. So what are the contents which pass through the vena cava opening? The first one is inferior vena cava and the right phrenic nerve. And what is passing through the esophageal canal or esophageal opening? There is the esophagus and the vagus nerve. And aortic opening, we have an aorta, we have a zygous vein, as well as thoracic duct. These are three things which are passing through the aortic opening. So their vertebral landmark is very important with regards to the openings. Vena cava opening T8, esophageal opening T10, and aortic opening at T12. So this is important to know. And as a whole, diaphragm, the nerve supply of diaphragm is phrenic nerve, having a root value of C3, C4, and C5. Now, about the portocaval anastomosis. We have already dealt with the portocaval system when we're talking about the venous drainage of the entire body. But here, I'll be dealing only about anastomosis, okay, and what it causes. Now, you have to remember that we can see a picture over here. You can see a picture over here. Okay, now we're not talking about the colon. That is a different part. Now here we are talking about the portocaval anastomosis. You can see here in the esophagus, umbilicus, as well as the rectum, there are three levels there is anastomosis. Okay, now we'll see if at all there is a clinical condition that is going to happen. What is the ultimate result of it? Now remember, if at all a patient comes up with a history of chronic alcoholism, now basically what will happen, a portal hypertension will, the patient will come up with a portal hypertension. And when there is a portal hypertension, that will cause pooling of the blood. The pooling of the blood means blood will, get pooled up in one particular place. Now, if at all in the rectum, if the blood gets pooled up, that means the dilatation of the veins will happen over there, and that will lead to nothing but the hemorrhoids. If the same thing happens in the umbilicus, we call it to be caput medusae. And if something happens, same thing, dilatation of the veins happen in the esophagus, we call it to be esophageal varices. So three places, three levels of anastomosis: the rectum, umbilicus, and the esophagus. In the rectum, we get hemorrhoids. In the umbilicus, we get caput medusae. And in the esophagus, what we have is esophageal varices. This was what was important regarding the clinical importance of portocaval anastomosis. Now, next one, coming to the muscles of the anterior abdominal wall. You can see these are the muscles of anterior abdominal wall. The external external oblique muscle, we have an internal oblique muscle, and then transverse muscle, transverse one. Okay, transverse is like this. Next one, we have a rectus abdominis. We have a pyramidal trimester, cannot be shown here. Okay, so now what is very important to know in this? In this, the important ones are the nerve innervation and the action. Okay, talking about the external oblique muscle, its nerve innervation is the intercostal nerves and the subcostal nerves. Intercostal and the subcostal. T7 to T11 and T12. So this is the innervation of external oblique. And what it does, it compresses the abdomen, flexes the trunk, and is active in forced inspiration. It is active in forced inspiration. So this is what happens in the external oblique. Now, internal oblique, again, we have the first two nerve innervation are the same. Apart from that, iliohypogastric and ilioinguinal nerves are also been involved. Iliohypogastric and ilioinguinal. Okay, and again, it compresses the abdomen, flexes the trunk, and active in forced inspiration, forced expiration. So, external oblique and the internal oblique will be having the same action. Now, coming to the transverse, you can see transverse is over here. So lateral 1/3 of the inguinal ligament, okay, leave that. We'll see the nerve innervation. There is again the nerve innervation of internal oblique and the transverse is one and the same. Okay, and the nerve innervation of external oblique and rectus abdominis is the same. Okay, so what does transverse do? Transverse abdominis, what it does? It compresses the abdomen and depresses the ribs. Compresses the abdomen and it depresses the ribs. This is what the transverse abdominis do. Now, next one is the rectus abdominis. Remember, rectus abdominis is a vertical muscle. Okay, vertical muscles. Okay, and transverse abdominis, and then maybe external oblique and internal oblique. They are basically flat muscles. Flat muscles. So, talking about rectus abdominis. Okay, I have already mentioned they have the same nerve innervation like that of the external oblique, and the function is depressing the ribs and flexes the trunk. It depresses the rib and flexes the trunk. Okay, so this is the action of rectus abdominis. Now coming to pyramidal, it is having an innervation only from the subcostal nerve, and it acts to tense the linea alba. We have a linea alba, right? Linea alba. It helps to tense the linea alba. That is the action of pyramidal. Pyramidalis actually. Okay, pyramidalis. Next one we're talking about cremaster muscle. The cremaster, the nerve insertion is, or nerve innervation is genitofemoral, and what it does, it helps in the retraction of testis. Helps in the retraction of testis. So these are the anterior abdominal wall muscles, and it's nerve innervation and the action. Okay. So next one we're talking about is the posterior abdominal wall. Now talking about the posterior abdominal wall, we have three main muscles, that is quadratus lumborum, then we have psoas major as well as psoas minor. Okay. Now in sometimes we can even include diaphragm also in this, but we are dealing only with these three. You can see over here, psoas minor this is psoas major, we have quadratus lumborum. Okay. Now the nerve innervation is of quadratus lumborum is subcostal nerve and L1 to L3. Nerves from L1 to L3, spinal nerves. Fine. Now action is it depresses the rib, that is 12th rib. It depresses the 12th rib. Okay. And flexes the trunk laterally. And flexes the trunk laterally. So basically what will happen is extension and lateral flexion of the vertebral column. Okay. There will be extension and lateral flexion of the vertebral column by quadratus lumborum. Now, what does psoas major do? Psoas major, they basically help in, it is written that flexes thigh and trunk. So, in short, I'll tell you, flexion of the vertebral column. Flexion of the vertebral, sorry, not that, sorry, I've mistaken. Psoas major, right? Psoas major, flexion of the thigh at the hip and lateral flexion of the vertebral column. I'll write over here. Psoas major helps in the lateral flexion of vertebral column, whereas psoas minor will help in flexion of vertebral column. One is just a lateral flexion, other one is complete flexion. Okay, and quadratus lumborum I've already mentioned, that is extension and lateral flexion of the vertebral column. All right. Extension and lateral flexion of the vertebral column. Okay, and nerve innervation of psoas major is by L2, L3, and psoas minor is L1. This is regarding the muscles of the posterior abdominal wall. Posterior abdominal wall. So, next one coming to the muscles of perineum. Now, this is a little important one. Muscles of perineum. Okay, now remember that the muscles of perineum, they interlace and converge in the perineal body. They interlace and converge in the perineal body. So name of the muscles of the perineum are very important for you to know. Okay. There are two superficial transverse perineal. You can see transverse perineus muscle. We have two. One over here, other one over here. Two. We have two deep transverse perineal. And beneath that, we have deep two transverse perineal. We have two bulbospongiosus. We have two levator ani. We have longitudinal muscle core of the anal canal as well as the sphincter ani externus. Okay. So totally we have 10. We have 10 muscles in the perineum. 10 muscles in the perineum. And that is two superficial transverse perineal muscle. Then we have two deep transverse perineal muscle. We have two bulbospongiosus. We have two levator ani. We have one longitudinal muscle coat of the anal canal, and the other one is the sphincter ani externus. Okay, this is the the name of the muscles of perineum, and this is very important for you to remember. You need to remember this. So again, I'll repeat. There are two superficial transverse perineal. There are two deep transverse perineal, two bulbospongiosus. Then we have two levator ani, and we have longitudinal muscle coat of anal canal. And then we have a sphincter ani externus. Sphincter ani externus. There are a few other information which you need to know. A little information you need to know regarding the neurovascular supply of perineum. So remember, perineum is being supplied by, I'll overwrite over here, pudendal nerve having a root value to S2 to S4. Okay, root value S2 to S4. The arterial supply is internal pudendal artery. Internal pudendal artery. Okay, so remember, nerve innervation is by pudendal nerve, and the blood supply is through internal pudendal artery. So this is something which you need to remember regarding muscles of perineum. Okay, thus we have finished the major topics of abdomen. The organs as such will be taken in a different class. So next one, the last one is about the lower limb. So we'll see a little about the lower limb. The first one we are going to see is the femoral triangle. Femoral triangle. Now, before we come into the other details of the borders and what are the contents and all that, let us little go through a little details about the femoral triangle as such. So the shape of the femoral triangle is a little important one. So what is the shape of the femoral triangle? Femoral triangle is wedge shaped. Remember, it is wedge shaped area and located within the superior medial aspect of anterior thigh. Anterior thigh. This is very important to know. A wedge shaped area located within the superior medial aspect of the anterior thigh. This is one thing which you need to remember. And the next one about femoral triangle is regarding the borders. Okay, now coming to the base of the inguinal triangle. Sorry, not inguinal triangle, femoral triangle. We have an inguinal ligament, that is the base of femoral triangle. The base of femoral triangle is the inguinal ligament. Coming to the floor. In the floor, we have iliacus muscle, we have psoas major, we have pectineus, as well as we have adductor longus muscle. Okay, these three are actually the major ones. Laterally, on the lateral border, we have the medial border of sartorius muscle. Remember, the medial border of sartorius muscle is the that is present in the lateral border of femoral triangle. I'll write over here the medial border of sartorius muscle. Medially, or the medial border is again the medial border of the adductor longus muscle. Okay, so we have lateral border is the medial border of sartorius. Medial border, we have the medial border of adductor longus. Okay, now apart from that, we have a superior border also. Superior border, that is the base, right? and the base is inguinal ligament. Fine. Base is otherwise termed to be the superior border. Floor we have already mentioned. Psoas major, pectineus, and adductor, these are the most important major muscles which form the floor of the femoral triangle. And finally, we have iliacus also. Okay. Now, next one is the contents. Contents are basically femoral artery, femoral nerve, and femoral vein. Apart from that, we have the lymph nodes also. Okay. Now, where does the lymph nodes form? Lymph nodes, stay, and that is in the femoral canal. So that rather than telling that the contents of femoral artery, nerve, and the vein and the lymph node, it is better to say femoral artery, femoral nerve, femoral vein, and the femoral canal. And in the femoral canal, we have the lymph nodes as well as its vessels. Okay, so this was about the femoral triangle. Okay, so next one we're talking about is popliteal fossa. Popliteal fossa is yet again an important area in the lower limb. So popliteal fossa is basically nothing but a diamond-shaped area which is located on the posterior aspect of the knee. Remember, it is present in the posterior aspect of the knee. Okay. Now, I've already mentioned that it is a diamond shape, right? Now it has four borders, and these borders are formed by the muscles in the posterior compartment of the leg and the thigh. These borders are formed by the muscles of the posterior compartment of the leg and the thigh. We'll see what happens to the borders. First one, we have a superior medial border. Superior medial border. And that is, first one is the semimembranous. Semimembranous is the superior medial border. Next one, what we have is a superior lateral border. And that is a biceps femoris. You can see over here, this is a semimembranous. This is a wedge shape. Yeah, sorry, not wedge shape, diamond shape. Diamond shaped. Okay. Here, superior medial border, we have the semimembranous muscle. In the superior lateral border, we have the biceps femoris. In the inferior medial border, this is the gastrocnemius, and that is the medial head of gastrocnemius. And in the inferior lateral border, we have the lateral head of gastrocnemius, as well as we have the plantaris. So this is the borders of popliteal fossa. Once again, I'll repeat, in the superior medial border, we have semimembranous. In the superior lateral border, we have biceps femoris. In the inferior medial border, we have medial head of gastrocnemius, and the inferior lateral border, we have lateral border of gastrocnemius as well as plantaris. So this was regarding the borders. Now coming to the floor, this is also important to know what is there in the floor of the popliteal fossa. So the floor of the popliteal fossa is formed by the posterior surface of the knee joint capsule plus we have popliteus muscle and the posterior part of the femur. So these are the ones which are there in the floor. Okay. And what is the roof of these? Roof we have popliteal fascia as well as skin. So borders we have seen, we know what is there in the floor as well as what is there in the roof. Okay. So next one is the contents of popliteal fossa, very important one. Contents medial to lateral will say we have a popliteal artery, then we have a popliteal vein, and we have the tibial nerve, as well as a common fibular nerve. So these are the contents of popliteal fossa. Popliteal artery, popliteal vein, tibial nerve, and the common fibular nerve. Common fibular nerve is otherwise termed to be a common peroneal nerve. Okay.